it's important to remember that culture-bound assumptions can masquerade as value-neutral. White, middle-class male standards cannot be used as a standard of healthy psychological development. But some cognitive behavioral therapy assumes these kind of standards to be normative criteria, and patients should conform to them. This is a very socially conservative philosophy which risks putting the therapist into the position of promoting conformity to the social order, as if that kind of adaptation equals psychological health. However, some people are not willing or not able to adapt their behavior to the standards and values of the dominant culture. It's important that the psychotherapist not unwittingly serve the socially dominant power group rather than the individuation process of the individual who may want to swim against the tide. Liberation psychologists have long pointed out that cultural factors such as sexism and the devaluation of women have a very important role in the development of difficulties such as the borderline personality disorder. Now, a word about the question of evidence. Some kinds of evidence are needed for the practice of psychotherapy. We need to be sure we're doing something helpful. But what I'd like to do is discuss the question of what we actually mean by evidence, because evidence is a notoriously ambiguous term. The question of the nature of evidence is a long-standing discussion among philosophers of science. We're looking for ways in which we can support or discount our belief in a hypothesis. So evidence must have some bearing on the truth or falsity of a theory. The conceptual problem is to decide what counts as evidence, how to decide when data or clinical findings become evidence in favor of a particular theory, whether some kinds of evidence carry more weight than others, and if so, who decides which kinds of evidence are which. It's also important to look at the ways in which evidence is actually used in practice. We have to remember that raw data themselves are not evidence. Data has to be interpreted, and data only become evidence in the light of a pre-existing paradigm or theory or even a metaphysical framework. To a large extent, the response to the question of evidence depends on the type of problem we're trying to study. We need the right kind of evidence for the right kind of question we are asking. Some questions lend themselves more to qualitative than to quantitative approaches. The type of evidence we need within the natural sciences is different than the type of evidence we need within depth psychology. Depth psychology doesn't have the rigorous laws of the kind found in Newtonian physics. Empirically based psychology requires that evidence can be independently observed and verified. And this field has a preference for quantifiable measurements. But we need different kinds of evidence to decide that psychotherapy based on depth psychology is effective. Empirical research based on quantitative evidence is only one kind of evidence. But the depth psychologist has no reason to privilege this rather than other types of evidence. We think it's a mistake to insist that only what can be measured counts as evidence. There is evidence based on systematic observation, single case studies. These are also forms of evidence. They give us knowledge or information about the question at hand. The relationship between the psychotherapist and the patient is another important source of evidence. The practitioner's personal life experience is evidence. Clinical experience and tacit knowledge based on years of practice are all forms of evidence. These forms of evidence can be made explicit, they can be articulated, they can be debated, and they can be verified or discounted by the community of the psychotherapist's peers. Evidence from the accounts of patients who've been in this kind of psychotherapy is also important. These are qualitative forms of evidence. Now, they're often devalued by empiricists who believe that they're just anecdotal, they're just too idiosyncratic and too subject to personal bias. But in many clinical situations, that's all we have. In all cases, empirically derived research evidence has to merge with the practitioner's knowledge and with clinical experience, and not all of that is empirically based. Some researchers are interested in what works, but in this case, a lot depends on what we mean by works, and for whom it works and in what context something works. If we consider symptom removal or the treatment of a particular syndrome, such as depression, then empirical validation means showing that one form of treatment leads to a better outcome than another. But for depth psychology, the situation is more complicated. We're not just interested in changing behavior or removing symptoms. For Jungians, for example, depression is a signal from the unconscious or from the transpersonal self that something needs attention. And from this point of view, depression may lead to an important course correction in a person's life. For the depth psychologist, therapy that removes the symptom of depression without attention to the underlying message doesn't work at all. So partly based on experience with their personal psychotherapy, partly based on the qualitative evidence that I've talked about, depth psychologists believe that depth psychotherapy fosters personal development and self-understanding as well as producing symptom relief. These are, in a way, different goals. Since the effects of this therapy on the individuation process of the individual can unfold over many years and may also affect members of the person's family, when should we judge its effects? How could we find a matched control sample? If we were to apply the question of the efficacy of depth psychotherapy to studies of large populations of people who've been in this kind of therapy, we would find results, and these have been found, that apply to particular individuals, but not to others. Whether or not the results are statistically impressive for the whole population would be irrelevant to the individual for whom the therapy has been helpful. Statistically derived knowledge always has to be interpreted in terms of an individual person. What is good statistically may not be good for a particular individual, and vice versa. Remember that the managed care industry has a vested interest in controlling the type of psychotherapy it will reimburse, even though there's a good deal of evidence that different types of psychotherapy produce similar results. The implication of insisting on a specific approach is that all patients with the same diagnostic labels, such as depression, require the same treatment. This is manifestly not true, given the uniqueness of the individual and the need for therapeutic flexibility. Many people with exactly the same DSM diagnosis and the same list of symptoms may be at very different developmental levels and may have very different personality structures and need different approaches. The value of psychotherapy based on depth psychology is that it takes into account the unconscious. It takes into account the spiritual dimensions of life, complexity and mystery. The evidence that it helps is found in our greater self-understanding and deeper connection to this mystery. Thank you.